Good afternoon, everyone. Welcome to another session of Classroom Series. We have here with us Dr. Kali Charan, who will be giving us a talk of acute ischemic stroke, which is a clinical emergency. So, we will discuss how to identify it and the management of acute ischemic stroke. Over to you, Dr. Kali Charan.
Good afternoon, everyone. Sorry for my voice. Actually, I'm suffering from a URTI. My topic is acute ischemic stroke. The font is actually not that visible. Uh, so we can start with. So what is stroke? Stroke is defined as an abrupt onset of neurological deficit that is attributable to focal vascular causes. Stroke is why stroke is important? Stroke is important because stroke is the second leading cause of death worldwide, next to ischemic heart disease. So mostly I'll be focusing on ischemic stroke. So our treatment strategies will be between intravenous thrombolysis and endovascular treatment. So when would you initiate the treatment? We should initiate the treatment as soon as possible. There is a term called time is brain. So that time is brain is very important. If the patient has come within the window period, we don't have to waste time. We just have to start the treatment. So now coming to statistics, I know statistics is a bit boring. Still, we have to know the amount of burden the stroke has caused to worldwide hospital setups. So each minute of ischemic stroke causes destruction of 1.9 million neurons, 14 billion synapses, 7.5 million miles of myelinated nerves. Just imagine 5 miles of myelinated nerves. So basically, every year around 14 million new stroke cases comes. Most of them are ischemic stroke. Around 9 to 10 million of all the 14 million are ischemic stroke. Generally, they happen in age above fourth decade, but nowadays it is very common in the young generation, around 7%, which is quite significant. Reason you all know: sedentary habits, hyperlipidemia, diabetes, hypertension, stress. These are all factors which can lead to stroke in young patients. Men and women, stroke doesn't have any gender bias. Mortality: ischemic stroke has 5 years mortality of 60%. Hemorrhagic stroke overall mortality is very high. 1 out of every second patient dies within 2 days. Hemorrhagic. So now coming to the classification. Generally, broadly, stroke is classified between ischemic and hemorrhagic stroke. Ischemic is generally can be due to any plaque, due to atherosclerosis, can be due to embolic stroke, due to any cardiac murmur, cardiac VF or AF. Hemorrhagic stroke can be intracerebral, can be subarachnoid. Intracerebral is more common, but we will be discussing on ischemic stroke, which can be due to atherosclerosis, can be due to embolic stroke. So what are the risk factors? I've already mentioned you: hypertension, diabetes, hyperlipidemia, smoking, obesity, sedentary lifestyle. Can you see all these things? All these risk factors are nowadays very common in most of our middle class society, in younger patients also, especially doctors also. So we have to treat the cause of stroke. So every time a stroke is diagnosed, we should know the cause of stroke. So cause and risk factors are not synonymous, but they have to be treated independently. So risk factors should be treated independently and cause should be treated independently. So now coming to the pathophysiology of ischemic stroke. As you all know, that ischemic stroke happens when there is an occlusion in the vessel, in a cerebral vessel. So if there is an occlusion in a cerebral vessel, there will be decreased cerebral blood flow, which stimulates anaerobic metabolism pathway, which causes decrease. If there is decrease in cerebral blood flow, there will be decreased ATP, decreased glucose, decreased oxygen. So if there is decreased ATP, the sodium potassium ATPase pump will get inhibited. If it gets inhibited, all the sodium goes inside the cell and will drag water also from outside and causing cellular swelling, which is the first stage of stroke, which is called as cytotoxic edema. After cellular swelling, there will be cell death, apoptosis, cell death, and cell death will lead to release of all inflammatory mediators, which can lead to opening of blood-brain barrier, and that opening of blood-brain barrier will lead to vasogenic edema. So vasogenic edema comes after cytotoxic edema. Importance of cytotoxic and vasogenic edemas event are very important in managing a stroke, because this thing only defines how you will treat a stroke. Cytotoxic comes first, vasogenic comes second. So there are few stroke mimics such as seizure, hypoglycemia, hypertensive encephalopathy, Wernicke encephalopathy, CNS tumor, drug toxicity. These all should be differentiated from stroke. Seizure, generally you will have a seizure history, patient have aura or something like that. Hypoglycemia, patient can be a known case of diabetes. Sugar, you generally in stroke protocol you always do a capillary blood glucose. So if there is low blood glucose, that is a the stroke can be mimicked by hypoglycemia. Hypertensive encephalopathy, patient can be hypertensive. Patient must have cortical blindness, blurring of vision, headache. These are all signs of hypertensive encephalopathy. In generally in acute ischemic stroke, headache, blurring of vision doesn't happen in anterior circulation stroke. Posterior circulation stroke, it can happen in PCA stroke. Wernicke encephalopathy, history of alcohol should be there. Ataxia, ophthalmoplegia can be there. CNS tumor onset is generally gradual. Stroke onset is acute. Drug toxicity, lithium, phenytoin, carbamazepine, these all are stroke mimics. These all toxicity can cause a stroke-like symptom. So how will you identify a stroke? It can occur in community or in hospital. First responders are generally family members, relatives, or your close family members. Paramedics sometimes, nursing home practitioner many a times, sometimes. Recognition, the single most important history is to take the time of symptom onset. Time of symptom onset defines the treatment of stroke. It is the cornerstone of stroke management. So there are multiple pre-hospital checklists. You can see if there is a stroke or not. Fast, be fast. So there was a study which was published in Frontiers of Neurology 2022. They compared fast with be fast. They considered fast as a better pre-hospital stroke indicator than be fast. So fast, you see the face. If there is one side deviation of face, arms or legs can be weakness in arms or legs, or speech difficulty can be there. If out of these more of the symptoms are there, it is most likely a stroke. You have to call the emergency team and shift the patient to the stroke unit. Other pre-hospital strokes: Cincinnati pre-hospital stroke scale, Los Angeles stroke scale. Los Angeles stroke scale, I have to mention particularly, it is nowadays very much emphasized because of the higher sensitivity as well as specificity of its scale. Its sensitivity goes up to 90% and specificity goes up to like 97%. It is very highly specific. 97% is too much. So generally they see three things: facial paresis, hand grip, and arm drift. The more the number, the more the likely of stroke is there. So these are all pre-hospital stroke assessment scales. Even if you don't remember these scales, just remember three things. When was the last patient was last seen normal? What was the BP of patient, and what was the blood glucose of the patient? These three things are very important for pre-hospital assessment of a stroke. Last seen normal. When was the patient seen normal last? Blood pressure and capillary blood glucose. Now the patient has come to emergency room. Now you'll have to assess and intervene. How will you assess? The first and foremost, the most important thing: don't waste time in stroke. How you don't waste time? You don't have to change the stretcher from ambulance to hospital stretcher. It is not required in stroke. Clothes, you don't have to change the clothes of patient. When a stroke patient comes, if a patient is having signs and symptoms of stroke and it has come, you don't have to change the clothes. Okay, you don't have to take detailed history. Detailed history is not required. Only the onset time, medication, what the medication is in patient, and NIHSS, which I will be discussing later, should be taken. Now ABC, airway, breathing, and circulation should be seen. SpO2 less than 94 or BP of less than 90 mmHg or BP of more than 185 by 110 should be treated aggressively. BP should be maintained less than 185 by 110. 2 large bore IV cannulas should be taken. 2. One should be for IV fluid, one should be for IV thrombolysis. Sample collection should be taken simultaneously when you are securing a cannula. In sample collection, the most important sample you have to take is blood glucose. Capillary blood glucose you can take. You have to see if there is hypoglycemia, rule out hypoglycemia. Platelet count INR can be sent when the patient is on oral anticoagulants or any other drugs. As I already told, no detailed history is required. So there is a score called NIHSS, which is generally to define mild, moderate, and severe stroke. Mild stroke, generally they have mentioned it into 11 points. 11 points. Every point has got multiple numbers. So overall, 42 is the maximum point a patient can have. So these are all CNS examination like consciousness, visual acuity, gaze, facial palsy, motor, limb ataxia. All these things are there. So if the number is 0 to 5, it is called as mild stroke. If the number is 6 to 15, it is moderate. Greater than 15, severe stroke. So generally, moderate stroke are ideal candidate for thrombolysis. Mild stroke, it depends on the condition of risk benefit ratio. Generally, you can also go for thrombolysis in mild also. Now symptoms I have mentioned: headache. Headache is not that common. Facial palsy, speech dysarthria, motor weakness. Risk I have already mentioned. You can see obesity, hypertension, alcohol, cigarette, coffee. These are all we should avoid all these things if we are hypertensive and high risk of stroke. So these are all vessel-related stroke symptoms. If there is an MCA stroke, right MCA stroke, there will be right gaze deviation, left-sided weakness. If there is a left MCA stroke, left-sided gaze deviation and right-sided weakness will be there. If there is an ACA stroke, contralateral leg weakness will be there. PCA stroke, contralateral hemianopia is very important. Cerebellar stroke, generally ataxia, nystagmus, imbalance will be there. So these are all typical vessel-related stroke symptoms. Now, why I call time is brain? Because if you get late for treating the patient, there might be no perfusion. I'll come to this later. But ideal time to door to physician time should be less than 10 minutes. Ideal door to stroke team should be less than 15 minutes. Ideal door to CT initiation should be less than 25 minutes. Ideal door to CT interpretation should be less than 45 minutes. Ideal door to drug time should be less than 60 minutes. This is very important. 60 minutes, less than 60 minutes should be ideal. So this patient has come for stroke management. This patient has come within the window period with ICU occlusion. You can see there is no MCA and ACA distal to that. Now post thrombolysis, ACA and MCA both are visible. So the stroke has been thrombolized and reperfused. Now coming to penumbra versus core. What is penumbra? Penumbra is ischemic. It is an ischemic zone, but it is reversibly dysfunctional tissue surrounding a core area of infarction. That means core is irreversible, penumbra is reversible. That means there is decrease in cerebral blood flow in penumbra, but cerebral blood volume is still there. The tissue is not dead. Tissue can be salvaged. So more the penumbra, the more the penumbra, the more the more the patient can be revived. So generally, just a second. So generally CBF is more than 18 ml per 100 gram per minute. Penumbra 12 to 18 ml per 100 gram per minute. Penumbra the CBF is, it is decreased but not decreased to a critical level. But in core it is decreased to a critical level. EG and SSCPs are reduced, but it is not vanished. So that is why penumbra is important. The more the penumbra, the more the tissue can be salvaged. Now penumbra versus core. Penumbra versus core, just you can see in penumbra cerebral blood volume is increased, but cerebral blood flow and mean transit time is decreased. That means the mean transit time is the time taken for blood vessel or blood or RBC to go from one place to another. So mean transit time increases in penumbra, but it doesn't stop. But in core, the CBV is also decreased to a critical level. Mean transit time is also increased to a critical level, and CBF is decreased to a very critical level. So core is generally cannot be salvaged. Penumbra can be salvaged. So for this reason only, stroke management has been enhanced so much. Now coming to the role of CT scan. What is the role of NCCT? NCCT head is not to diagnose stroke. NCCT head is performed to rule out hemorrhage. That's it. If you have a patient with stroke symptoms, with normal NCCT, treat it. Within window period, treat it. You don't have to wait for any other signs in CT to come. Still, there are few early signs in NCCT brain, such as hyperdense MCA sign. This is, you can see in the proximal MCA. M1 MCA, there is hyperdensity due to thrombus. Loss of insular ribbon can be there in a distal MCA stroke. Lentiform blurring can be there. Loss of gray-white differentiation, sulcal effacement. These two generally happens later. This is dense MCA sign. This is MCA in the M2 territory. So this is also dense MCA sign. So these are all early signs of the stroke in CT. Now coming to the aspect score. So aspect score is nothing but to define the severity of stroke in an MCA territory stroke. So they have what they have done. They have divided the MCA territory into 10 zones: M1, M2, MCA, M3 at the level of basal ganglia, M3, M4, M5, M6 at the level of corona radiata, and overall the basal ganglia to other four. So every region has got 1 point each. So if there is hypoattenuation in one of those regions, that point will be deducted. So that means the more the attenuation in multiple areas, the more the number is getting detected. So the lesser the aspect score, more the severity of stroke is. So why aspect score is very important in stroke management? Generally, lower the aspect score. If you go for thrombolysis of low aspect score, you may lead to land up into hemorrhagic conversion of stroke. So generally, prognosis decreases with decrease in aspect score. So now coming to role of MRI. What is the role of MRI in stroke? Routine use of MRI is not excluded. Is to exclude microbleeds before administration of IV Alteplase is not recommended. So cerebral microbleeds, if you have to see to administer IV Alteplase, this is not recommended for MRI. Still, MRI has very big role in stroke management. MRI is useful in detecting minor stroke and differentiating ischemic stroke from mimics. In posterior circulation stroke, MRI is generally helpful. MRI is also useful to detect wake-up stroke, where the time of onset is not known, by obtaining DWI-FLAIR and see for any mismatch. Like if the patient has come to you, I'll discuss it later. MRI is also important to manage a patient coming after 6 hours of stroke to your stroke unit. You can obtain DWI MRI and MR perfusion and go for mechanical thrombectomy. I will discuss it later. So now coming to the management. What are the main management in stroke? Most important is IV thrombolysis, followed by mechanical thrombectomy and antiplatelet treatment. Sonothrombolysis, these days it is not recommended. And other EVTs are also there. Mostly we will be discussing on IV thrombolysis, mechanical thrombectomy and antiplatelet treatment. So IV thrombolysis. IV thrombolysis, the most common drug we use is Alteplase. So what are the recommendations? If the patient has come within 3 hours of stroke to you, and if the patient's age is more than 18 years of age, so IV Alteplase administration within 3 hours is equally recommended in patients who is more than or less than 80 years of age. So you have to give IV thrombolysis if the patient has come within 3 hours of stroke, irrespective of the age of patient. The patient should be more than 18 years of age. For mild but disabling stroke, mild but disabling, remember disabling, I told you 0 to 5 before. 0 to 5, if there is any disability, you can treat that disability with IV Alteplase. It is indicated within 3 hours of symptom onset of AIS. For severe stroke, IV Alteplase is indicated within 3 hours of symptom onset of AIS. These all are level 1A recommendations. So how these recommendations came across? The most important landmark trial was NINDS TPA trial. It was for Alteplase as a TPA to be used within 3 hours. Then this 3 hours was increased to 4.5 hours by conducting multiple other trials, ECAS 1, ECAS 2, Atlantis B trials. And these all trials were conducted, and they recommended Alteplase for 4.5 hours. Now criteria for IV thrombolysis. If the patient has come within 3 hours, your criteria should be if the patient should be more than 18 years of age. Patient should be more than 18 years of age. BP should be less than 185 by 110. Blood glucose should be more than 50 mg%, and there should be no hyperdensity in CT. I told you aspect scores. Less the aspect scores, more the hyperdensity, and less your treatment success will be there. Then, if the patient has come 3 to 4.5 hours, all those above I have mentioned should be there with patient's age. Now age has come. Before within 3 hours, no age barrier. After 18, anybody can get thrombolyzed. But in 3.3 to 4.5 hours, age should be less than 80 years. Patient should be non-diabetic, no prior stroke. Patient should not be on any oral anticoagulants. NIHS score should be less than 25. That means it should be moderate stroke. less than 1/3 of MCA territory involvement. You already know aspect scores. Now, what are the contraindications? There are few contraindications for stroke thrombolysis. Like if the patient has come with unknown time of onset, wake up stroke, ICH. If there is ICH in the CT scan, you have done CT to rule out hemorrhagic conversion. If there is no hemorrhage, you can go for stroke. If there is hemorrhage, it is contraindicated. Clinical features suggestive of SAH. SAH is also an hemorrhage. Intraaxial neoplasm, any glioma or any tumor, aortic dissection, infective endocarditis. Patient is on direct thrombin or 10A inhibitors or GP2B3A inhibitors. Within 24 hours, patient has taken. Platelet count is low. Coagulopathy is there. Then you should avoid giving Alteplase. So now protocol. Coming to protocol, how will you administer IV Alteplase? Generally, you infuse 0.9 mg per kg of actual body weight. Maximum 90 mg you can give over 60 minutes. 10% of all of this will be given within 1 minute as bolus, followed by remaining 90% should be given in 60 minutes. It should be ideally done in the stroke unit. If the patient has signs of headache, hypertension, nausea, vomiting, these are all signs of raised ICP, can be due to hemorrhage. So you first and foremost is to stop thrombolysis. Stop thrombolysis, go for CT scan. You have to stop thrombolysis and go for CT scan. Now, how will you? Now after that, if this is not going, then you give thrombolysis, measure BP every 15 minutes for first 2 hours, 30 minutes for next 6 hours, and hourly for next 24 hours until after IV Alteplase treatment. If there is any increase in BP of more than 180 to 105 mmHg, you can start with antihypertensive. Generally, we prefer labetalol. If labetalol doesn't decrease your BP, you can go for hydralazine, nimodipine, or any ACE inhibitor. Delay placement of NG tube, indwelling catheter, or any arterial line. Better not to do any intervention during the first 24 hours of Alteplase. Obtain a CT, follow-up CT and MRI at the 24 hours IV Alteplase before starting any anticoagulant and antiplatelet. Now coming to Alteplase versus tenecteplase. So this is very peculiar. Alteplase is to tenecteplase. Many prefer Alteplase, many prefer tenecteplase. So the origin of tenecteplase is quite peculiar. It was discovered in 1993, and it was actually FDA approved for acute coronary syndrome in 1999. But it took almost 20 years to get it approved in stroke, acute ischemic stroke. So Extend IA TNK trial was first landmark trial which actually approved the use of tenecteplase in stroke management, and the results were better than Alteplase. Then they conducted a part 2 of Extended IA TNK where low dose of tenecteplase was used, and the results were also promising. So coming to Extend IA TNK trial, it was published in 2018 NEJM. You'll just observe most of the landmark trials in stroke management were published in NEJM 2018. I don't know why, but it is there. So tenecteplase versus Alteplase before thrombectomy of ischemic stroke. So they concluded that if tenecteplase is given, there is higher incidence of reperfusion and better functional outcome than Alteplase among patients with ischemic stroke treated with 4.5 hours after symptoms onset. So tenecteplase was better than Alteplase if it was given in the window period. Now coming to a situation where the onset of stroke is not known. That means a patient has come after waking up and told the doctor that my right hand and right leg is not moving. That means you don't know when the stroke has happened. The stroke might have happened on, suppose a patient has come to you at 8 o'clock and told that after 7 o'clock I woke up, nothing is, my right hand and right leg is not moving. So stroke might have happened on 6 o'clock, 6:30, or 5 o'clock, 4 o'clock, 2 o'clock, 1 o'clock. You don't know. So you don't know the window period. How will you treat this condition? So I already explained you about cytotoxic edema and vasogenic edema. Cytotoxic is cellular swelling, vasogenic is interstitial space, accumulation of fluid in interstitial space. So cytotoxic edema happens within minutes to hours, and vasogenic edema can take up to days. So generally, if there is a cytotoxic edema, that stroke can be revivable. And if there is a vasogenic edema, that means most of the stroke area is generally a core has become core. There is no penumbra remaining. So how will you diagnose this? This is cytotoxic or this is vasogenic edema. So they came to a point that DWI and FLAIR, diffusion weighted imaging, which actually sees cytotoxic edema, and FLAIR imaging, which generally see vasogenic edema. If there is a DWI FLAIR mismatch, if there is a DWI FLAIR mismatch, that means there is a hyperintensity in DWI, but there is no hyperintensity in the FLAIR. That means there is the patient's stroke condition is in the cytotoxic edema phase, but it has not gone to vasogenic edema phase. So in that way, this stroke is acute or hyperacute. It can be treated. Alteplase can be given. That stroke must have been happening within 4.5 hours. So just see, there is a just see this picture. DWI, there is hyperintensity over MCA territory. There is no hyperintensity in the FLAIR. Here you can see hyperintensity in the basal ganglia region, but there is no hyperintensity in the FLAIR. But when there is no mismatch, you can see hyperintensity in both areas. These cases you won't start Alteplase. Then you can go for other treatment. So DWI FLAIR mismatch was very important. So the landmark trial which happened in August 2018, NEJM, was wake up stroke trial, MRI guided thrombolysis for stroke in unknown time of onset. So they concluded that in patient, just a second, in patient with acute stroke when with an unknown time of onset, intravenous alteplase guided by mismatch between DWI and FLAIR in the region of ischemia resulted in significantly better functional outcome and numerically more intracranial hemorrhage. So hemorrhage was more, but functional outcome was better than placebo at 90 days. So this was the outcome. Outcome was better, 53%, and placebo was low, but bleeding was there. What if the onset is more than 6 hours? Now coming to, we have already discussed on onset is 1, onset is 4.5 hours. Now if the onset is more than 6 hours, how will you treat? Then come to endovascular treatment. Endovascular treatment has a very strict eligibility criteria. Age should be more than 18 years. Pre-stroke ranking score should be 0 to 1. NIHSS should be more than 6, less than 25. Aspect score, I've already discussed, should be more than 6. Major vessel should be there. ICA, M1, MCA generally preferred. The reason is in study published in Euro Intervention 2021, the MCA and ICA stroke endovascular treatment resulted in 58 and 57% of clinical success with respect to MRS, then 30 to 27 to 40% of success in other vessel occlusion. You can use in other vessel also, but it is recommended for M1 MCA and ICA. Then if the period is less than 6 hours, then the above criteria is indicated. If the period is less than 6 hours means 4.5 to 6 hours. If the period is 6 to 16 hours, then dawn and diffuse criteria comes. Dawn criteria, generally age can be less than 80, more than 80, less than 80. Your infarct volume should be less than 31 ml. If more than 80, the infarct volume should be less than 21 ml. More the age, the less the infarct volume should be there. And diffuse criteria, infarct volume should be less than 70. And ischemic tissue is to core ratio, that is very important, should be more than 1.8. So this is dawn and diffuse criteria, and for 6 to 24 hours dawn criteria is generally used. Now coming to dawn trial. What was dawn trial? It was published in NEJM 2018 NEJM. Just see. So they included those patients who has clinical infarct mismatch within 6 to 24 hours after stroke. They divided the patient into thrombectomy and standard care group. Thrombectomy 107 and standard care 99 patients were there. Thrombectomy group had very good results in utility weighted modified Rankin score. They concluded that outcome with respect to disability were better with thrombectomy group than standard care alone, with patient coming in 6 to 24 hour of last seen normal who had DWI clinical severity mismatch. That means infarct volume is very low, but clinical severity is very high. So that mismatch should be there. Then diffuse criteria, this also got published in Feb 2018 NEJM. I don't know why stroke is very This for NEJM. Diffuse 3 trial, 6 to 16 hours. Their inclusion criteria was infarct volume should be less than 70 ml. The ischemic tissue volume to ischemic infarct ratio should be more than 1.8. So these two are very important. NIHSS score should be more than 6. Modified Rankin score should be less than 2. Just see this example. Here, this is computer software related thing. So software diagnosed that volume of ischemic score is 23 ml and volume of perfusion lesion, that means penumbra, is 128 ml. That means mismatch volume is 105, 128 minus 123, and mismatch ratio is 5.6. Now see if it is meeting the diffuse criteria or not. Initial infarct volume less than 70 ml, 23 ml less than 70 ml. Mismatch ratio 5.6, more than 1.8. That means this patient can be salvageable by endovascular treatment. So endovascular thrombectomy can be done in this patient. Now coming to the difference between DAWN and diffuse criteria. Eligibility criteria I have already mentioned. DAWN 6 to 24 hours, diffuse 6 to 16 hours. DAWN is only intracranial ICA was taken or proximal MCA was taken. Here extra or intra both ICA were taken and proximal MCA were taken. Here mismatch ratio was more important. Here the infarct volume was more important. So this was the difference. Infarct volume for DAWN and mismatch ratio for diffuse. What about TIA, transient ischemic attack? So it is defined as minor stroke with NIHS less than 3, as they had the best short-term and mid-term outcomes. How will you treat TIA or not? There was a trial, PRISM, where Alteplase versus aspirin was taken. The trial was prematurely terminated, but whatever the initial results were, it was not favorable for functional outcome at 90 days with Alteplase. But since then, many other trials also happened. SITS, ISTR, GWS registry, they defined good functional outcome, mortality and risk of ICH were same in mild stroke treated with 0 to 3 or 3 to 4.5 hours. So treatment depends on the patient condition. I told you before, mild stroke with disability can be treated by IV Alteplase. Mild stroke without any disability, you see if it is required or not. Antiplatelet treatment 24 to 48 hours after onset should be started. If the patient is in Alteplase, aspirin delayed until 24 hours later. This is a level 1A evidence. Efficacy of tirofiban, iptafabat is not well established. GP2B3A inhibitor, apixima, potentially harmful. And if the patient is in minor stroke, you can directly start 21 days dual antiplatelet for 21 days within 24 hours. It's a class 2 evidence, chance trial, which was published in NEJM, but here it is 2013. Now coming to anesthesia management, GA versus MAC or conscious sedation. There are many trials, you know, that Goliath trial and stroke trial, which was supporting GA. Here Siesta and MRT, they support conscious sedation. So we generally go for GA in our institute. So we follow Goliath and stroke trial. Goliath trial was also was published in JAMA, and this and stroke trial was published in stroke. In Goliath, they concluded that anterior circulation GA did not result in worse tissue outcome, worse tissue and clinical outcome compared to conscious sedation. And in stroke trial, they said that endovascular treatment of acute ischemic stroke, there is no difference found with GA or conscious sedation in 3 months neurological outcome. Now, what are the pros and cons of GA? Pros are immobility, pain control, airway protection, GA, and better picture quality. Cons are generally hemodynamic changes, time taken, additional workforce also. Conscious sedation, smoother hemodynamics, intra-procedural neurological evaluation can be done. Cons are picture quality is not good, patient movement can be there, no airway protection, prolonged procedure time can be there. So anesthetic management, what are the recommendations? Recommendations, GA is recommended in those patients who are already intubated for medical reasons. GA is recommended for all the uncooperative patients. GA is preferred in posterior circulation stroke. Generally in posterior circulation stroke, there is a risk of aspiration. Lower cranial nerve can get damaged. So GA is preferred. Tracheal intubation is recommended for patients with low GCS, signs of brainstem dysfunction, posterior circulation stroke, nausea, vomiting, hypoxia, hypercarbia. It's a level 2 evidence. Conscious sedation are feasible for cooperative patients who can protect their airway. Patients with conscious sedation, we should always be prepared to convert it into GA. We should always be prepared. we should not take it for granted that conscious sedation will never be converted into GA. So GA things should be prepared if you are giving a MAC to patient. Anesthetic technique, pharmacological agent should be individual, patient to patient. Supplement oxygen support can be given, recommended. Anesthetic management. Now coming to anesthetic management. Pre-procedural evaluation should be done as quickly as possible. See, it should not delay the EVT. Time is very important. Time is brain. Anesthesiologists should follow ASA standards for emergency procedure. FiO2 of more than 94% and PO2 or 60, more than 60 mmHg should be titrated, should be maintained. Standard ASA monitoring should be done. Normogapnia, BP of more than 140 but less than 180, and diastolic BP of 105, less than 105 should be used. Fluid and temperature glucose management, euvolumia, normoglycemia, normothermia, hypothermia. Hypothermia is not recommended. There was a Cooley's trial or ICUS trial. These all recommended against hypothermia. So generally normothermia, euvolumia, normoglycemia, and protocol-driven insulin infusion, these are all should be done. You can put an arterial line, but that should not delay your endovascular therapy. You can put, if the patient is not stable, you can put a arterial line, and but it should not delay the endovascular treatment. Anesthesiologists should be prepared to administer heparin throughout the procedure as requested by the neurointervention team. Anesthesiologists should be prepared to administer protamine immediately to the patient who has received heparin in case of ICH or iatrogenic SAH. So they should be prepared for heparin, they should be prepared for protamine, they should be prepared for all the catastrophe intervention team can go with. ICH, if there is an ICH, how will you manage? We'll immediately start protamine. BP should be maintained to more than 140 by 140 mmHg SBP. Rapid lowering of BP is not recommended. Labetalol can be given if the BP is very high. So post-stroke care, what are the things? Stroke units are recommended. Supplemental oxygen support can be given when SpO2 is more than less than 94%. BP management should be done. Hypotension, hypovolemia should be corrected. Normothermia should be maintained. Normoglycemia should be there. Dysphagia screening is very important. I'll come to dysphagia screening later. Nutrition, within 7 days, start feeding, enteral feeding. DVT prophylaxis in case of immobile patient without contraindication of IPC in addition of routine care, it is recommended. Antibiotic routine use is not recommended. Don't use antibiotic without any evidence of infection in stroke patient. Complications, generally, majorly, there are 3 major complications: cerebral edema, seizure, hemorrhagic transformation of stroke after IV Alteplase. Cerebral edema, prediction of cerebral edema, younger age, if the stroke has happened in younger age, 7%, remember? So younger age cerebral edema is very common. High NIHSS score, that means severe stroke, or more than 50% of MCA hypertension is there. Ventriculostomy is recommended in treatment of hydrocephalus. If ventriculostomy fails, you can go for decompressive craniotomy. So now coming to malignant MCA infarct. It is a type of cerebral edema which is malignant. So it is defined as rapid neurological deterioration due to the effect of cerebral edema following MCA territory stroke. It generally consists of cytotoxic vasogenic edema. Mortality can go up to 80%. Just imagine 80%. And the most common cause of death is transtentorial herniation. Just see, almost whole region of MCA is hypoattenuated. This is malignant infarct. Generally, there are medical management, but generally, if this type of malignant infarct is there, go for decompression. So, medical management, head elevation, hyperventilation. As neuroanesthetists, we all know this. Hypothermia, hypertonic saline, barbiturate. Now, coming to decompressive craniotomy. When would we undergo decompressive craniotomy? There were 3 major trials which defined which age group is needed for this decompression. Decimal, Destiny, Hamlet, all these 3 trials. They happened in Lancet and Stroke. They were published in Lancet and Stroke. So if the age is less than 60 years of age with unilateral MCA infarct who deteriorate neurologically within 48 hours despite medical therapy, decompressive craniotomy with dural expansion is reasonable because it reduces mortality by close to 50%, with 55% of surgical survivors achieving moderate disability or better MRS, and 18% achieving independence at 12 months. It's a very good number. So if the age is less than 60 years, go for decompression. And if the age of 60, more than 60 years, what will you do? You'll see the risk benefit. If there is a benefit of decompression, that anyways the patient is going to die, and there is a hope that decompression can improve, so you can go for that. More than 60 years, many a times patients relatives are not that cooperative, so these are all factors for not to undergo decompressive craniotomy. Seizures. Prophylactic use of anti-seizure not recommended. Recurrent seizure should be treated as normal neurological condition. Anti-seizure drugs should be selected based upon specific patient's characteristics. Now coming to hemorrhagic transformation after intravenous Alteplase. Risk factors: older age, greater stroke severity, hypertension, all the comorbidities, diabetes, ischemic heart disease, congestive heart failure, AF. These are all risk factors for hemorrhagic conversion. So there is a classification called ECAS classification of hemorrhagic conversion following IV thrombolysis. They are broadly divided into HI and PH. HI is hemorrhagic infarction, PH is parenchymal hematoma. HI1 is small punctate petechiae. Just see, small punctate petechiae is there, and HI2 is confluent petechiae. Sorry for this. PH is homogeneous hyperdensity. HI means petechial hyperdensity. PH is homogeneous hyperdensity or hematoma. PH1 is less than 30% of infarct bed, and PH2 is more than 30% of infarct bed with significant mass effect. Generally, in PH1 and PH2, we go for a decompressive craniotomy and hematoma evacuation in our center. Management of ICH following IV thrombolysis. If there is an ICH following IV thrombolysis, you have done a CT. The CT is showing PH1 hemorrhagic conversion. First and foremost is, I told you before, Alteplase should be stopped. Send all the investigations. Emergency CT already done, ICH confirmed. Go for blood products and blood. Cryoprecipitate can be given if fibrogen level is less than 200 mg per deciliter. Pool SDP can be given. Tranexamic acid can be started. Urgent neurosurgery consultation should be taken. If the bleed is very big, urgent neurosurgical intervention is required. Critical care management includes BP management, ICP management, cerebral perfusion pressure management, MAP, temperature and glucose control. Now coming to stroke rehabilitation. This is very important topic in stroke rehabilitation. Generally, we come across in the stroke unit. Post-stroke patient has a lot of disability. Generally, gaze palsy, visual neglect, sensory problem, motor deficits, ataxia, and these are all very commonly happening in stroke patient. But what is the point of most interest is dysphagia. It occurs in 40 to 80% of the patients following a anti-circulation stroke. Why it is very important to rehabilitate dysphagia? Because it severely hampers quality of life. Just imagine if the patient is dysphagic, he is not able to get oral feed. Just imagine what can be his quality of life. His quality of life will be very low. So dysphagia should be treated aggressively. First should be screened and then treated. So it affects more than 50% of stroke survivor. Normal swallowing generally requires appropriate function of, just see, almost every part of brain is required for swallowing. Cortex, sensory cortex, motor cortex, parieto-temporal cortex, this basal ganglia, thalamus, cerebellum, brainstem, everything is required. Every area of brain is required for swallowing. So if there is a stroke, you invariably see that there will be dysphagia because almost all the area is involved in the swallowing. So any of this area can lead to dysphagia. Most feared complication is aspiration pneumonia. So just see, if there is dysphagia, aspiration pneumonia is the most feared complication. But the most common complication is dehydration and malnutrition. Majority of these patients, they recover swallowing function within 7 days. But still many doesn't improve. So there are multiple dysphagia screening are there. Standardized swallowing assessment, TOR BSST. Generally the gold standard is fluoroscopy. Standardized swallowing is the most specific and TOR BSST is the most sensitive. But in our institute, we generally use gugging and swallowing screen, GUS test. It was first published in BMC Anesthesia 23. it is divided into two tests. One is indirect swallowing test, one is direct swallowing test. Indirect swallowing test, we see for the patient's vigilance for 15 minutes. We see if there is cough or throat clearing is there. See for saliva, swallowing of saliva. If the swallowing is successful, there is no drooling, there is no voice change during saliva swallowing, we give it one point each. The sum should be is maximum is 5, and 5 should be there to jump to the next phase, which is direct swallowing test. If the point is 4/5, again next day we start with indirect swallowing test. So if the point is 5, then we go for direct swallowing test. Direct swallowing test, first we give semi-solid, then liquid, then solid. Semi-solid generally we give custard, or we give this dahi. Liquid we generally give water. Solid we give bread or roti. So these tests also have deglutination, cough, drooling, voice change. So first semi-solid, if patient passes semi-solid 5/5, then go for liquid next day. If it is failing, then next day semi-solid should be repeated. Liquid, then it passes liquid, then get solid next day. So this is how we assess our dysphagia screening in our ICU. Gus test. Now, dysphagia therapy. Many therapies are there: postural adjustment, altering bolus characteristics, consistency, viscosity, volume of bolus, increased volitional control, effort swallowing, Mendelssohn maneuver, supraglottic safety swallow, tongue hold exercise, shaker exercise. These are all done by our esteemed physiotherapist. EMG and neuromuscular stimulation are newer techniques which increases the awareness of swallowing, retrain the pharyngeal musculature, improve swallow function, and promote reorganization of motor cortex. So to conclude, I'll just say that acute stroke therapy is one of the most important advances in therapeutics of neurological disease, and the future of new treatments looks promising. Thank you. I'm done. Hello? Am I audible? Uh, Excuse me?
Thank you so much. Am I audible? Hello,
Yes, yes.
Dr. Kalichak, am I audible?
Yes, ma'am. Audible.
Yeah. Thank you for the wonderful presentation. So I just had a few doubts. Uh, so when do you do MRI at all before you decide for a thrombolysis?
Ma'am, it is not audible.
It's not audible. Just a second.
Ma'am, generally we do CT perfusion, MRI case to case, ma'am. In NIMS Delhi, we generally go for CT perfusion if the patient has come with a wake up stroke.
Oh, so your
We see
practice
for
is to
mean
go for
transit
a
time
CT
and CBG,
perfusion for a
CBF,
wake-up stroke.
Penumbra we see.
Hello.
Yes, yes, yes.
So your practice is to go for a CT perfusion for a
Yes,
wake-up
yes. We
stroke.
go for CT perfusion.
Okay. Because over here
Yeah,
we
generally
follow
we go for
MRI
that. We see for Penumbra
wake-up
and
stroke protocol.
see how much the Penumbra is.
Okay, fine. All right. So
Okay,
have you
DWI
ever come
flare we
across?
see.
Okay. So have you come across ICH following
I'm
Alteplase
not,
infusion
ma'am.
or
Sorry, ma'am.
have you come
Yeah.
across
Many a times. Many a
ICH
times.
following
I
Alteplase or
was working in
tenecteplase
Max. We have
administration?
come across.
Okay. So how did you
I have
manage
seen
it?
even PH2. We have seen
Okay.
PH2. We called the neurosurgeon, and the patient
Evacuated.
underwent this hematoma evacuation.
So how did you manage the coagulation part of it?
We have very good at that time when I saw we diagnosed the hemorrhagic conversion. that time blood products were very easily. We give the bleeding was there, but patient was stable at that time. Immediately, that patient underwent decompression and hematoma evacuation. Blood and blood products were given. That's it. The BP, the most important thing is BP. We have to manage BP. So I guess we started.
Correct.
BP was on higher side. It was actually on higher side.
So
It was
did
more
you
than
administer
200.
any cryoprecipitate or anything like that prior to taking the patient for surgery or intra procedure?
Not cryo in that case. Uh, we have used cryoprecipitate, but not in that
Okay.
case. We use
Okay.
cryoprecipitate regularly. In AIMS library also we
Okay.
use cryoprecipitate.
Okay. Okay. There was just
Our blood bank is
one
very
case where
cooperative.
we encountered. Yeah. There was just one case where we encountered an ICH following tenecteplase, not tenecteplase, Alteplase administration, and then we had to give cryoprecipitate and rush the patient to the OT table. But I that was my first case of an ICH following thrombolysis. But I thought the patient would bleed a
Okay,
lot,
so
but actually it did not happen
without
like that.
fibrinogen,
I
is
think
it wise to give
I don't know
cryo or
exactly. Yeah, and I think the cryo took care of the bleeding part,
but
so
ma'am,
it was very
without
well functioning.
fibrinogen level?
We
Yeah.
did not do any fibrinogen levels because the
Okay.
time was very short.
Without
So we had
fibrinogen,
to
can we
rush the
use
patient for the
cryoprecipitate?
procedure. Yeah, we had to rush the patient for the procedure, so we have to give some blood products. So,
Fine.
cryoprecipitate is a reversal agent for the
Definitely.
tenecteplase. So we just gave that. Okay, thank you so much for this wonderful discussion, and we'll get back to you next week for journal
Thank
club
you.
and every second Saturday, Sunday, and fourth Saturday, Sunday for the case presentations. Thank you so much.
Thank you so much for the opportunity, ma'am.
Thank
Thank you.
you.